There's billboards between Albuquerque to Espanola that say, do not use alone. Does that mean we're enabling somebody?
That campaign and the metrics show that it's one of the most successful campaigns that they've ever done. And at the same time, people hate it. The thing that makes me so sad about the people that would say that it's enabling is that we have lost so many beautiful people. I'm sure many dozens of people just here in New Mexico and hundreds of people across the country. If people are using alone, they're much more likely to die. And that person is somebody's kid, somebody's tia, somebody's cousin, somebody's loved ones. They are someone to somebody. And I don't think that it's reasonable to say, well, they should just die instead. I mean, because that's basically what you're saying, you know?
Today we are joined by Athena Huckaby. She is a public health professional and advocate for people with substance use disorders. She also is an overdose prevention and harm reduction educator, a member of the Opioid Settlement Advisory Council, and co-founder of Grajeda-Huckaby Low Barrier Housing Fund. Athena, thank you so much for being here with us today.
Oh yeah, thank you so much for having me. It's really great to be here. I just wanted to issue one small correction. I actually am no longer on the Opioid Settlement Advisory Council, only because I took a full-time job where I'm actually managing those funds for Doña Ana County. So I can't be on the advisory council anymore, or it would be a conflict of interest. So, but that's really exciting. I'm still really involved in what's happening with the funds, and yeah.
As you're telling us this, I wanted to see if you could share more about what you're actively doing and how you're serving the people of Las Cruces and Doña Ana County.
I work full time for county government. I probably won't talk too much about that, but yes, I'm the special projects manager there, and so I'm overseeing the opioid settlement funding and also the Behavioral Health Reinvestment Act funding. But in my personal life, I'm an advocate for people with substance use disorders, and one of the things that started me along that path was founding the Grajeda-Huckaby Low Barrier Housing Fund, and I founded that with my friend and colleague Roxy Grajeda. So she was working at the time for Department of Health, and I was working at the time for a treatment provider. And basically, just what we were seeing all the time was all of our clients, you know, needing help with housing, and so I thought it was great to do that together with her. And so I'm continuing the work with that. And then I also do some patient advocacy work. I do a lot of naloxone education. I do a lot of provider education. So meeting with providers and teaching them how to prescribe buprenorphine, classes on, you know, best practices around non-stigmatizing language, tools for families that have family members that have substance use disorders, all kinds of things. I'm on the New Mexico Behavioral Health Planning Council. Yeah, so just really trying to keep that harm reduction voice in all things as much as possible.
How do you find balance in all these committees and supporting all these spaces?
I think I'm really lucky that my full-time job, whatever that is, for a long time now has supported me in being active in those committees. So prior to this, I was doing outreach for a drug treatment clinic called Ideal Option, and they were always very supportive of me being on, you know, going to lots of meetings and being on lots of committees and meeting people, because that's one of the ways that you get the word out. That was great. And now with Doña Ana County, you know, I have to know what other counties are doing and sort of what's going on. It has allowed me, though, to, like you asked that question about balance. Before, when I was doing community outreach, I was working in a statewide capacity, and that was getting really overwhelming. And so being able to pull back more to focus on Doña Ana County specifically has cleared a lot of things off my plate. And that has become increasingly important to me, that balance, because it's very easy to burn out in this field and in this work. And I think, like, people say that, but I don't know if we all really know what it means. And if you really do burn yourself out, it can take years to recover, or you might have to leave the industry and not even come back. So, and that doesn't serve anyone. So trying to take care of myself is part of it. It's difficult sometimes.
You've created a loud voice here in New Mexico for harm reduction, recovery support, housing advocacy. It's amazing. And I think so many people recognize you and associate you to those causes. But you grew up in New York City.
I actually grew up in Illinois.
Oh, I'm sorry.
That's okay.
You mentioned to me that you spent time in New York City.
Yes.
You were finding your way through your own recovery and found yourself into the medical field. Mm-hmm. But what was that time of life or season of life looking like for you?
Yeah. Well, just first of all, to backtrack, I think some people do think that I'm from New York City because I did live in New York City for 11 years and I went to school in New York City. So I finished school in New York City. So I finished my bachelor's degree and I got a master's degree there. But I'm originally from a really small town in Illinois with about 500 people in it. And the joke about my town, which is not really a joke, is that it has 3 churches and no stoplight. It reminds me a lot of places I've been in New Mexico, very agriculturally based economy. My family my mother mostly supported us through food service work, and my dad is a retired Teamster truck driver, but my family have mostly been farmers, through the generations. So I moved to Phoenix when I ended up living in Virginia, and then I moved to Phoenix when I was 19, and then I moved to New York City in 2004. And I found myself, they say if you can make it there, you can make it anywhere. New York City is very difficult. I was robbed, my first week there. I was working for the Elizabeth Arden Red Door Salon and Spa. I had been working for them in Phoenix and I transferred in New York, and I was working in the phone room. So like answering the phone, booking appointments for clients. And I was doing my commute, to see how long it would take me. And I was walking down the street and somebody bumped me really hard. And, I thought that they were really rude, but I didn't think anything else of it. And then my wallet was gone from my purse, with like my last $170 that I had in the world. And it's a very hard place, and then at the same time, it has a lot of opportunities. And so that time in my life, I got a job with a medical provider. She actually called to book an appointment at the salon, and I answered the phone, and she decided that she wanted me to come and manage her office. So that's how I got into healthcare. So, she wanted me to just be a receptionist. She didn't want to, but eventually I managed her office. And
what was it in that conversation that you guys had that something struck a chord with her?
She is a doctor, and so she called. She had been going to the salon, I guess, for 30 years, and I thanked her at the end and said, thank you, Mrs. Steinberg. We'll see you on Wednesday. And she said, actually, it's doctor. And I said, I'm so sorry. Let me change that in your file right now. I can't believe that nobody has noted that. And I said, thank you, Dr. Steinberg. We'll see you on Wednesday. And so she told her stylist that, in true Dr. Steinberg fashion, that I was the only intelligent person she had ever talked to at the salon and that she wanted my information. So I think just, as a woman in the field, right, acknowledging another, she worked really hard and she should be called doctor.
Yeah. Can you tell us more about New York? You said that it's a hard place.
The thing they say about New Yorkers is that they're kind but not nice, so people will absolutely help you get what you need. They just don't want you to waste their time while they do it, so I was really thrown off when I first moved there that people don't give you eye contact. But that's just not something that you do. It's a way I think that New Yorkers give each other privacy in public, because we're also on top of each other all the time. But yeah, I saw that even in the gynecology practice. Even though I'm working for this gynecologist on the Upper East Side of New York, she mostly specialized in menopause care. So we weren't doing OB or anything. And, I remember Gloria Steinem walking by me one day, and just on the sidewalk while I was outside smoking a cigarette, so, not that she wasn't a patient. She was just, that would be a HIPAA violation, but, anyway, she was just walking by, and just all the people that I would see. But even there, I saw, what I'm trying to say is that even there, I saw that people were struggling, and even just struggling with healthcare and health policy. I remember one of the reasons I got interested into getting a public health degree, and specifically a policy and administration degree, is that this was pre-Obamacare, and I saw people, their claims would be denied for pre-existing conditions, for things like vaginal infections, and I'm arguing with the insurance company, like, do you know how this works? This is like denying care for a cold because somebody had, the flu last year. It's not the same flu. It's, but just they didn't seem to know anything about women's health or, even their own policies. And I just found it so, if these Upper East Side women were having a hard time getting their health insurance to pay for the things that they needed and were their right to obtain, what must it be like for the women that weren't coming to that practice, that I didn't see?
Yeah. After graduating, then you stayed in New York for how long, and how long were you practicing in public health?
When I first moved to New York, I knew immediately that New York was not for me, but we sort of had this like uneasy peace. And I think for myself, I was struggling with my own alcohol use disorder. And I was in an abusive relationship, but I, got away from this person. And when I said it's hard, it's also hard in that way that, maybe you have a job where you're making enough money where you can support yourself and pay your rent, but you can't save anything to leave. And so I really was in this sort of like dead end spot where I had this apartment. I had this job that I liked, which was great, but I had this apartment that I could barely afford in Staten Island at that point. And yeah, I was just struggling. And so I went on my own journey of getting sober from alcohol and decided to go back to school. And so I went back to school and I started really slowly, just like a class or two at a time so that I wouldn't overwhelm myself. Finished my bachelor's degree and then got my master's degree in 2017 and moved to Las Cruces like immediately. Yeah. So, I think I graduated in December and I was here by February. Yeah.
How did you come to be in New Mexico?
I had lived in Arizona for 7 years, and Las Cruces, honestly, initially was a place where I could land, that I knew somebody and could sort of gather my bearings and not have to work right away and figure out what I wanted to do. I was actually just telling my husband that I remember coming up to Santa Fe and meeting with a couple of people at the Department of Health and realizing that I probably wouldn't be able to afford to live in Santa Fe, and, would I commute from Albuquerque or, and I was like, oh, and then I learned about this town, Bernalillo, and so I was trying to decide what I was going to do. And then luckily I didn't have to move. I was able to get a job with the health department in Las Cruces, and they had just gotten funding through the prescription, it's the Prescription Overdose Opioid Related Deaths Grant, or the PDO grant. So that was a grant distributing naloxone. So I got that job and started distributing naloxone. So that was really my first official public health job other than administrating medical practices in New York.
You said something in our conversation previously that you were practicing harm reduction before you knew what it meant. And it's interesting to me because being in a public health profession, that even public health professionals might not be practicing harm reduction.
I didn't learn anything about harm reduction until I got into my master's level classes. And even then, it was another student, this guy, Matt Curtis, that I still know and I'm really happy to be connected with professionally. But he's the first person that said the words harm reduction to me. And it's because he was already working in that field, but taking these master's level classes. So it wasn't even mentioned in any of my courses specifically. He had to mention it. And then we worked that concept into our group project for that course. But I think that's the only time that it got mentioned in my public health career or in my, public health education.
As you've been doing this for quite some time, have you found that there's a lot of stereotypes or misconceptions about what harm reduction is?
Yes. And I also think that people are scared of it. I think there's a lot of fear and a lot of stigma. We were just talking, I did a Narcan training with some folks in Socorro earlier today, and they were telling me about how they had passed out some lock boxes. You know, a lot of communities are able to use prevention funds to buy lock boxes to store prescription medications. And so they had given out a lockbox to a family. And I guess one of the educators saw one of the family members in the parking lot at Walmart. And the guy said to her, well, my daughter's using it to store her cannabis. And she was kind of like, like, sounds good. I think people are, and that's harm reduction, right? She has younger siblings in the house and they can't get access to her cannabis because it's in a locked box. Was that the intention of the product? Maybe not necessarily. Was it used for something that maybe somebody who is against harm reduction is worried that things like that might be used for? Maybe. So I think it can be difficult to confront that reality that as long as somebody is reducing the harm that could be caused, that it's a legitimate use. I think people really struggle with that, and there's this whole conversation about like, well, is it enabling? And is it, this or that, as if somebody needs your permission to do anything,
There's billboards, I don't know if they go south, but between Albuquerque to Espanola, billboards that say, do not use alone. Mm-hmm. And I think, to me, it's great. To some, it could be controversial to see that. And you're right. Does that mean we're enabling somebody? And I think so many people have reasons to believe, yes, we're enabling people to use fentanyl because of that billboard.
It's really interesting. My husband was actually involved in that campaign, and the metrics show that it's one of the most successful campaigns that they've ever done related to this kind of messaging. And at the same time, people hate it. I mean, what do they say? Also, any publicity is good publicity. So sometimes a little bit of a controversial message, I think, can get the word across. But I think the thing that makes me so sad about the people that would say that it's enabling is that we have lost so many beautiful people that were very resourced. One that comes to mind is Dan Bigg. Dan Bigg was the original Narcan guy. He's the one that put naloxone in his trunk and distributed it to harm reduction programs all over the country, like the godfather of this. And he died of a drug overdose alone in his study, as I understand, and it was the harm reduction guy. He knew that you weren't supposed to use alone, and yet could not overcome the stigma and shame, or maybe we, his community, couldn't meet him where he was at for him to be able to say, hey, can you, I've decided I'm going to start using again. Can you be with me? And that none of us could be with him and that he passed. And that's not just Dan's story. That's the story of hundreds of people. I mean, I'm sure many dozens of people just here in New Mexico and hundreds of people across the country. If people are using alone, they're much more likely to die. And I mean, I think that for it to be a stranger to you, like fine, but that person is somebody's kid, somebody's tia, somebody's cousin, somebody's loved one, somebody's wife, husband, like they are someone to somebody. And I don't think that it's reasonable to say, well, they should just die instead. I mean, because that's basically what you're saying,
Conversations that I have with patients are in line with that. Are you using alone? And if you are, you need to have somebody with you. You need to have Narcan. It needs to be current to your prescription. Can I send you a current Narcan prescription? And that to people is surprising, I think, sometimes to hear somebody saying these things to them. Yes, maybe today they are not ready to make change to stop using. However, that conversation opens the door to them to have trust and to be willing to have the conversation down the road when they are ready to make change happen. And I think that's the point that people miss. it is not right now, but down the road, they might be a peer support that had that moment in their life where they had a realization, where somebody had a conversation about harm reduction with them, and it opened their eyes to understanding that there is safe spaces to talk about this, and there are people out there who are willing to, be real and have real conversations.
I think if shame healed people, then everybody would be healed by now. I love that. I saw this sticker once and it says, you can't hate yourself into being somebody lovable, and I think about that in terms of this discussion. Like if shaming and shaking our finger and telling people like, don't you think about your family and like, what's wrong, and all of these, if those worked, they would have worked by now. I mean, how many of us heard that,
Yeah.
Yeah, I really love that you have that conversation with your patients.
Yeah. And I am a nurse practitioner, but I know that there are a lot of medical professionals that aren't willing to have these conversations, and they set people up because they hear that one thing: methamphetamine use, fentanyl use, sex work. Why is this so harmful to our patients?
I can talk a lot about why it's harmful to the general population. I can cite studies about, stigmatizing language and how it actually impacts patient care in a negative way. I can talk about holistic care, like treating people as a whole person. I mean, I think for me, a lot of it comes down to personal experience. I wrote an article which got published in Filter magazine about Philip, my husband, and his journey with a lot of this. He had an experience at Presbyterian Hospital where he was seeking, he had to have 2 spinal fusion surgeries, and he was seeking care for that. And he had a positive result, a positive toxicology screen for methamphetamine. He's on Adderall. So, was that a cross reactivity? We don't know. They never gave him an opportunity to do a second test, and they, in fact, completely dismissed him from care. They did not give him a referral to another spinal surgeon. They did not give him treatment resources. When he called and said, could this be because of my Adderall? They said, we don't know. And when he said, I don't understand why I can't continue to be seen, they said, it's just our policy. So if in fact, one single positive toxicology screen can prevent any individual in the state from getting necessary medical care, I think I don't even need to talk further about how it's harmful. People, I say this all the time in my trainings, people that use drugs are devalued, shamed, and stigmatized. And most of their health concerns don't actually have to do specifically with their substance use, but with all of the things that go with the substance use, with the fact that those substances are not regulated. And so there are adulterants and all kinds of awful things that you don't even know. The fact that they don't have access often to behavioral health care, to good primary care. They don't want to go to the emergency room because they've already been treated horribly there many times. They don't want to, so they're trying to keep themselves from harm. And when we reinforce that, we just drive them further and further away from care. So I think those are a lot of ways that it's harmful.
Thank you for sharing that. You are saying something that happens so often to individuals and families. And then where do they go? How do they get care? And this system, as we've talked about, feels broken in a lot of ways. One of the conversations we've had is there's so many organizations, so many groups to help support people, but a lot of times they don't have a way to connect. So we might not understand that there's this group that's supporting pregnant women, and you might have that resource, and I don't know how to access it. Mm-hmm. I want to hear more about what you think are the barriers about these systems and why we can't find ways to connect them.
My experience in working is that people either find reasons to say yes or they find reasons to say no. And I think there are a lot of things about the system that are broken that make it easy to say no. I'm just pulling from this experience because it's so fresh in my mind, being in Socorro today. One of the peer support workers and I were talking there, and he was saying that he is allowed to drive people to their appointments. So like if they had an appointment with you, he would be allowed to drive to the appointment, but he's not then allowed to drive them to the pharmacy. So basically he has to then take them back home and drop them off and say, good luck getting your buprenorphine, right? That doesn't make any sense. But yet, I guess basically the place that he works for thinks that it's a liability. I don't know what their reasoning is, if it has to do with medication theft but I just find that if people really want to solve a problem, they can find a workaround. And I think that the healthcare system, as fragmented and broken as it is right now, does not incentivize finding those workarounds, and people are overworked and tired and trying to make the system connect. And I'm sure you run into it every day with patient care, where I've experienced it where if I decide to really lean in hard to help somebody, it can take 8 hours. I got to arrange everything. I got to make a lot of calls. We got to go here. We got to go there. Sometimes people don't pick up the phone and you have to show up. I think it's difficult, and I think we need a lot more. I think the thing they're calling it now is like high touch navigation services, where really the person can pick you up and take you to your appointment and take you to get your medication and take you, to the next appointment. And then, maybe you guys get some groceries and they take you home. But like people have lots of needs, and, I think we don't make it any easier for people to meet them most of the time.
Yeah. You said it's like an act of God trying to get these people from point A to point B to all the way down the line. I see that on a daily basis. People come to access methadone. They come for an intake. They've probably been putting this off for weeks to come to this appointment. Mm-hmm. And they come in that door. They don't have an ID. Those simple things are going to stop the intake process. And so how can this person have help if they can't simply get an ID,
And then you say, I'm sure, you refer them to somewhere that can help them get an ID, right? But then, so like you said, they've been putting off this appointment for weeks. They finally showed up. They can't get what they need. So they feel defeated, even if we try to help them not feel that way. And then we say, well, you can go to this place and they'll help you get an ID. Well, then that's another thing, right, that they have to do. And do they have to take public transportation and they don't have a phone? And what are the hours? And, it's just one more thing. To you or I or somebody, like with Philip, I feel very grateful that I have the degree that I do and the understanding that I do and the knowledge that I do and all of the things that he brings as well. And that we were able to leave the state and get him the surgery that he needed. But most people can't do that. And that's why it feels like an act of God. You start to get really involved in what people's needs are. And it feels to me often like a black hole, well, I can't go do this because I need to go do this first, but I can't do this because I need to do this first. And, just all these barriers stacked and stacked.
One of the biggest things that I see on a daily basis are running into problems with is housing. Mm-hmm. Every day. And how can people be in recovery if they don't have a safe place to live? And you have this awesome housing fund, and I just want to hear more about how this came to be and what it was that resonated with you enough for this to happen.
Well, the story is that I almost got fired from my job because, as you know, working for an opioid treatment provider, we are not allowed to purchase things like hotel stays, or pay people's rent or, buy them food because it's considered patient enticement. If we spend over a certain amount, I think the cap is like $15 per year per person on things like transportation and other needs, then we're considered to be engaging in patient enticement. So, which I can understand, right? That we don't, that there's a way there that it could be unfair. So I was working at Ideal Option, and a patient came in and the medical assistant called me and said, you know, Athena, you have to help me with this person. She's a grandma. She's got her grandkids at the, you know, the hotel that they're staying at. She's going to lose her room. I don't know what's going to happen to her. She's doing really good on our program. You know, can you try to figure this out? So that was the first time that I had really tried to figure it out. You know, I had been in all these meetings with all of these agencies that said they were able to help people with housing. And I think that people think that means like emergency housing, you know, that you can call and they can get this person into a hotel or an apartment or whatever. No, that was not the case. Like nobody had any emergency housing funds available at that time. It was a long wait list and a complicated thing. Then people were telling me to call churches. So I called a bunch of churches and I called the Salvation Army and I called, you know, one of these 8-hour things. I spent all day on the phone. I heard about this individual philanthropist in the Las Cruces area that sometimes does stuff like that. I reached out to her. Nothing for this person. And so I put it on my credit card. And it got found out and I got a verbal written warning and I almost got fired. So instead of thinking I can't do this anymore, I thought, how can I do this in a way that is legitimate, that serves the community, that I won't get fired for? And so I called Roxy and we were chatting about it and we were thinking about just doing even like have you ever seen those like rolling GoFundMes? Like it's just like constantly going.
Yeah.
And so we were thinking about doing something like that. But then we called Tara Winter, the CEO at the Community Foundation of Southern New Mexico. And I had also met her in meetings. And I was like, let's just call Tara and see if we can do something. And she loved the idea, you know, about setting up a fund. And she, you know, the language she used was really accessible to us. She was like, I can set it up so it's almost like that. You know, there's a donation link, but then it's a tax deductible donation. So people donate to the community foundation, but it goes to your fund. So we were like, great, let's do it. You know, and so we set up the fund in 2020 and it's been going ever since. And we managed to raise and spend around $70,000 a year, which is not a lot of money. And so I do try to keep it a little bit under wraps, you know, because I wish I could help everybody in the county and I can't, you know, not even in the county. I mean, Community Foundation of Southern New Mexico serves 14 counties south. So, you know, even Catron and Eddy and some of these other counties. But yeah, it helps me sleep at night that I can help at least a few people on the journey, you know?
I think that's beautiful that you're helping people with just having that roof over their head, being able to rest and not be worried. We know that housing is in such need. If there is no place to live, people will stay in active addiction. Just wondering if you can share maybe a story or something about someone that has rebuilt their life through your program.
There's a young woman in particular that I still am very close with that was living in an Oxford house and reached out to me while she was there. And she needed some help paying, you know, just for the Oxford house, which I think was like $140 a week, but she had fallen behind on her payments. And so we got her current. And then even now we continue to support her in a small way because she is still going to school. She and her child live in they were able to get into a program. So they live in a permanent supportive housing situation, but she's going to school full time. And so we're still picking up that little bit of rent, which is not very much, but helps her to not have to worry about trying to get that money from, you know, her child's father or, you know, and that way she can just focus on school, which is great. There was also one particular guy that really stuck with me. He was referred by a partner agency in Silver City and he came over to see us in Cruces and we got him into a treatment program, set him up at the hotel. I partner with the Super 8 hotel, one of the Super 8s in Cruces, and the owner is very supportive and great. So got him in at the hotel. and he went to the treatment program. We got him in for medication assisted treatment as well. And then he went on to move from the hotel into an Oxford house, got a job, self-supporting. Last thing I saw, he had gone on a trip to Washington, D.C. with the rest of the Oxford crew. So that was really neat. Like this guy that hadn't been out of, much out of New Mexico and getting to travel. And he just he looked so much better, and I was just so grateful for the opportunity to be able to help him. But, originally when I founded the fund, because I am a harm reductionist, my idea was that we were going to support people whether they were still using or not. But when you have such a small amount of funds, I can't unfortunately house everybody. And so then we really do focus more on people that are trying to get into a program, or make some kind of change or a transition. So maybe like from a hotel into an Oxford house, or from an Oxford house into an apartment, or, somewhere where there's like a gap. Maybe they don't have a deposit or whatever.
Yeah. And that's understandable. The need is so high. Mm-hmm. And what you're doing is making a huge impact. Even if it's a small amount, it's helping support people to move on and be able to stay in recovery, support their family, go to school, hold a job, have a career. Mm-hmm. So that's amazing.
Well, and then there are certain gaps that we also fill that, even the existing programs don't have. We don't have in Cruces right now, anywhere in Doña Ana County, anywhere where a mom can go with a kid. So, Santa Fe Recovery Center, right, allows, I think, one child under 8. There's the Aspen House, the transitional living program at the Mountain Center. I can't remember if it's one child under 5 or one child under 8. But what do you do if they have 2 children? Or what if their child is 9? Or what if, and so for this one, she didn't, they were closing down the Mommy and Me Oxford house at that time in Doña Ana. And so she didn't have anywhere she could go with her kid. I mean, in a way, by not supporting these families, we're supporting the idea that they should break up, that she should send her kid to live with somebody else, I guess, like while she gets her life together, when really the best place for her kid to be is with her. So.
Yeah. And I think in Albuquerque, maybe Suriname might be one program here, but there is a wait list, and it's sad that we don't have more access to those types of programs. Mm-hmm. You said for a long time that you were helping people one person at a time. Mm-hmm. Doing all the running around, helping drive them to appointments, drive them to the pharmacy. And now it sounds like you are looking at things from a larger scale, trying to make larger changes, whether that mean by policy changes. What has influenced that change for you?
Yeah, I mean, I got my public health degree in policy, so I've always been really interested in that. But I think it's really important, like you had said earlier, to have a balance. Policy is amazing, and I really love that work because it's a way that you can change a lot of people's lives all at once. And so I see the importance of that, but it's very slow. There's no dopamine chasing in that, right? It's very methodical and plodding and slow, and there's setbacks, and some things take years and years and years. There is sort of like an instant gratification for me to helping somebody right now, and that I know my way around the system, and so, and also it's rewarding, things like I helped a guy once. I picked him up at the, he was leaving the detox and he needed to go to an appointment and he needed to go to the pharmacy. So we did all of those things together. At the same time, I was in my personal life, I had just filed for guardianship of my aunt and lost. The judge didn't know anything about mental health. Told me that I was a busybody, basically our whole family, right? That we were control freaks. And so that was very hard to hear, but I just accepted it. And what else can you do? And tried to work through it in my own therapy. But the point being that I was able to help that guy that day. And that really helped me. It helped me to put things in perspective that, I can help people that are asking for my help, and it's really rewarding. And, you know, he even said to me, like, thank you so much, miss. I never would have done all this if, you know, because he would have had to take a bus, you know, from in 100 and whatever degree heat. It was summer in Cruces, you know, no snacks, no water, no nothing, right? To the clinic, from the detox to the clinic, from the clinic to the pharmacy, and then from the pharmacy back to the tent city. So, I mean, it took us 3 hours. I mean, I can't imagine. I don't even know if he would have been done with all of that in the day. At what point, how long do you wait for the bus before you give up? Yeah. You know?
I can relate to what you're saying about feeling that instant gratification when you're helping somebody. Mm-hmm. Because when I was working in primary care, I would help people, but maybe it wasn't fast enough for me. So an example of a person was like treating diabetes, you know, they often are not ready to make a change happen, but they are ready to have their insulin increased to increase their metformin. Yeah, we could do that today, but I was wanting more out of that feeling of instant gratification. And when I started treating addiction, I realized that this life-saving medication that I was offering these people was changing their life in that very moment that you gave them that medication. And I just felt like this is what I've been looking for this whole time, you know, ever since I started out as a nurse. And so I think we can all somehow relate to that feeling of when we are reaching our hand out to somebody and trying to help them, that feeling of this is making a change happen now.
Yeah, this is helping them right now.
Yeah.
Yeah, and I don't need to follow up in 2 years. I mean, it's great to follow up in 2 years and see where people are at, but that reminds me of I worked with a nurse practitioner that said that she feels like addiction medicine is the best kept secret in medicine. And she had had a history before that of working in ERs, in hospitals. And she was like, I saw these same patients in the ER and it was terrible, but then I see them in my clinic and it's amazing and I love them. So she really didn't know how she would react, but she said it's the most rewarding way that she could practice. And I thought that was so interesting.
Yeah. And I think why she said that is probably in the ER, oftentimes they are seeking out opiates and asking for pain control, asking for benzodiazepines. However, in addiction medicine, you can't prescribe those. And you have the ability to help somebody to finally make a change in their life and come to the realization that, no, I'm not seeking out opiates. I'm trying to not have withdrawal and I need to feel better. Mm-hmm. Well, let's help you do that.
Well, and I think that if we did a lot more addiction medicine in the ER would be an easier place to be too. I think Presbyterian actually, you know, which is funny considering the problems my husband and I had there, does a really good job at this with the peer support workers in the emergency rooms. And I think every emergency room everywhere, all over the country, should have a peer support worker and an addiction medicine specialist that help to connect people to treatment, start buprenorphine in the ER, you know, start methadone in the ER if needed, hand them off for care later. It's the standard of care, but it's not being done at most hospitals, I would say, in the US.
If you could change one thing about what's happening in New Mexico and the services that are out there for recovery, homelessness, what would it be?
This is like the magic wand question. You know, people are like, if you had a magic wand, what would you? I'm on the leadership committee of the Unified Prevention Coalition for Doña Ana County, and we talk a lot about primary prevention, and I'm always the voice that says that I think poverty prevention is primary prevention. I think that anytime you have kids growing up in poverty, it sets them up to have addiction later on down the road. And so I think that instead of focusing, I think that New Mexico's prevention system is really underfunded. And I think that it has mostly focused on kids that are older, so like that we're going to take your third grader or your fifth grader and tell them about how drugs are bad, or educate them about whatever, But that certainly didn't do much for me. It didn't prevent me from developing a substance use disorder. I think sometimes we focus on not wanting kids to experiment, but kids are going to experiment because that's what they do. If their brains were healthy and they experimented, they wouldn't do that substance and think, oh, this fixed all my problems and I want to feel this way for the rest of my life, because that is often the experience that I've heard in a lot of recovery settings, in a lot of, that there's something wrong there. And so I think we need to intervene much earlier with mental health, with infant mental health, with poverty elimination. I'm really heartened at this. I can see the acronym in my head. Community Action Agency partnered with FYI in Doña Ana County, specifically in Hatch, to do a universal basic income pilot. So basically they gave families $500 a month. I think it was for a period of 18 months with no strings attached, and then studied what those families did with that money. And they went back to school. They bought stuff for their kids. They, made repairs to their homes. There was no evidence that people spent this money, the majority of the money, in frivolous or, irresponsible ways. People get a windfall like this and they use it. So, if we have these $1 billion windfalls, why not something like some universal basic income to really lift kids out of poverty?
That's so cool. I had not heard about that, but you're right. We are often on the back end of things when we should be on the front end. And yes, prevention is key in all of this. And as much as we've talked about how much the system is broken, there has to be a reason why we keep going, Mm-hmm. But what gives you hope right now?
I can think a little bit more easily about what shores me up, which are my colleagues. I'm the chair of the Las Cruces Suicide Prevention Task Force, and the other people that are on that leadership team with me are amazing women that also do amazing work. And they are like my text besties all the time. And we're always gassing each other up. And that is really helpful. We're both part of this Signal chat of creators, mostly women and gender nonconforming folks that are doing a lot of content creation, and just seeing all of that messaging going out. I think what mostly gives me hope is knowing that people have the capacity to change if they want to, that nothing really does have to be the end of the road for people. And if they have the right help and resources, they can do really incredible things. And that's not to say that also some folks, are really dealt a crappy hand and can't pull themselves out, So I think focusing on the people that I can help gives me hope.
With your housing fund, if anyone felt moved by the work that you do and they wanted to donate or become involved somehow, how could they do that?
Sure. So my fund is held at the Community Foundation of Southern New Mexico. You can just Google Community Foundation of Southern New Mexico. They have a donate now link, and you can scroll down and find the fund and make a tax deductible donation. They'll send you a nice tax deduction letter and even their annual report. So that's really easy. You can send a check to them. You can donate online. You can put it on your credit card, whatever. And then I think if there are other ways that people want to get involved or give back, there's a lot of, I think, first of all, just looking around at what you can do in your own community. When I started the fund, my hope was that other community foundations and other funding entities would be able to replicate this. Like I had said, people either find ways to say yes or they find ways to say no. I found a way to say yes that's able to be replicated that other people could do, but yet I haven't really heard of anything like this being formed. And I don't know why, even though we have so much research about housing first and low barrier housing and how it helps to support recovery, it doesn't seem like something anybody's interested in funding, and the HUD rules are so complicated. And the only one that I've heard that's high profile that's been doing it is Mackenzie Scott, Jeff Bezos' ex-wife. When they divorced, she took half of his fortune and has been, giving away billions of dollars. And she gave away a lot of money to help to house for emergency housing for families. especially, which I thought was great. So I know that some of that money went to Community of Hope in Las Cruces, where I live, and they were able to use that money for emergency housing for families. But that's the only funding stream I've heard that does that kind of work lately. And I know that there is a small funding stream that comes from the state of New Mexico, but it's very small and it doesn't grow. I think for Community of Hope, it's around the same as our budget. So like $76,000 a year.
Athena, you have come here today because you inspire me. And I want to say that everything that you're doing, you are just a powerhouse in this line of work. And you inspire a lot of people, especially young women. And that's why I wanted to invite you here, just because I hope that I can be more like you and do more things like you. So just thank you so much for that.
I think mutual admiration is always the key to like friendships and these professional relationships that I'm lucky enough to have.
Yeah.
There's so many people in New Mexico, including you, that are doing really great work, and we all have to do it together. Like, I'm not a nurse practitioner. You know, I can advocate for the prescribing of buprenorphine and for use of methadone, but you have to prescribe it, right? I can't. So it all complements one another, and we all have big parts in the work to play.
Yeah. Well, I want to turn to the audience to just say that this space is made for anybody that wants to listen in and help support each other, who is struggling in their own recovery, or providers or professionals that are trying to learn from each other, or finding people to connect with, like Athena. Thank you so much for joining us here, and we hope to see you on the next episode. Please help me in this journey to help change the trajectory of our story. We are Project Basecamp, and we are climbing to recovery.